macrocytic anemia. Macrocytic anemia. And basically, well, what does it mean? It means that the MCV of the erythrocyte is higher than 100 femtoliters. And not only this, but because it's macrocytic anemia, it also means and that there is a decreased production, so there will be decreased reticulocytes. And this is pretty cool because actually the other things we see in blood, because there's decreased production on DNA, and we also can call this a intramedullary hemolysis. So some their erythroblasts form, but it doesn't go through all the ways, and there is a destruction of erythrocytes, but only in the bone marrow. This won't get into the bloodstream. That's why, but not the erythrocytes. So basically, if you check the blood, you will have also LDH increased, and also bilirubin, unconjugated bilirubin, but the reticulocytes will be decreased. So this is different from normal hemolytic anemias, where you have increased LDH, increased bilirubin, unconjugated bilirubin, and increased reticulocytes. Okay. And how do we divide macrocytic anemias? Well, we could still divide it into like only macrocytic anemias, macrocytic anemia only, and to megaloblastic macrocytic. So megaloblastic. And the most important cause of only macrocytic anemia is alcohol. In this case, alcohol causes it's directly toxic to the bone marrow. Okay, so toxicity to bone marrow. So remember, this is one of the examples. More interestingly, also with alcohol toxicity, in some cases you can see actually neuropathies, and especially remember, in rare cases, you know, some books they talk about posterior and lateral column signs, okay, like tabes, etc. So, but those are posterior or lateral columns signs. But this is very rare. But remember, most important is peripheral neuropathy. That's what is seen in alcohol. And this macrocytic anemia with the neurology sign, this is very similar to what? It is very similar to B12 deficiency. And B12 deficiency is at the other side, it's at the megaloblastic part, because two main causes of megaloblastic anemia, and megaloblastic is defined that in contrast to macrocytic only. In macrocytic you see only erythrocytes and neutrophils are normal, but in megaloblastic you see big erythrocytes larger than 100, rather 110 femtoliters, but also you see hypersegmented neutrophils. So they don't have like 2-3 segments, but they will have like 4, 5, 6, 10. And that is how the megaloblastic anemia is defined. Large erythrocytes with neutrophils with many segments. And as I said, there are two main causes. One of them is deficiency of B12 vitamin, or vitamin B12, and the other one is deficiency of folate. And only remember from now on, we have large storages of B12. We can survive like 4 or 5 years. We're ready, like with B12, but folate we have storages only for a few weeks. Okay, so basically, to be deficient in B12, there has to be some very long chronic process to get deficient. And let's get back to neurology. So what is very similar to alcohol poisoning, although that is only macrocytic anemia, is also in B12 peripheral neuropathy. And that is different from folate because there is none of it. There is no peripheral neuropathy. And also with B12, in rare cases, you can have lateral and posterior column signs, but that's again very rare. Okay. In contrast to vitamin B12, remember, folate has no neurology, minus neurology, and thus For example, if there's megaloblastic anemia and it's because of B12, you can normalize the you can normalize the anemia with folate supplementation, but you won't normalize it. But in case it's B12, you won't normalize the neurological deficit. So always think when there is a neurological deficit of B12 deficiency. Also, there is a difference in resorption. Remember, B12. First, we need a R factor, which is made in the saliva, and this protects the B12 against the gastric juices. And then we need a good pancreatic enzyme function to release the B12 from the R protein. Actually, R protein is it has many synonyms. So the one is transcobalamin 1, or also haptocorin. But R protein is the best to remember, I think. So you need good pancreatic functions that they will release the R protein from the bone to the B12, or I mean they will release the B12 from the R protein, and then you need intrinsic factor, which will bond and protect B12 till it gets to the terminal ileum where it is resorbed. So B12 is resorbed in the terminal ileum, and it needs many things for protection. R protein, then it needs pancreatic enzyme, and then it needs the intrinsic factor. In contrast to this folate, is fully resorbed very similar like iron. So remember duodenum and proximal ileum. Okay, so this is duodenum and this is ileum. Remember that as a place of resorption. So that's very important. And also remember, alcoholism also can create not only macrocytic anemia like over here, but also if the people are drinking only and not eating anything else, they will sooner or later get deficient, especially in folate, and maybe if they're very chronic in B12, because they're getting energy from the alcohol, but all the other important vitamins and other stuff are missing in the food. So at the end, they can, and also people like drinking only alcohol can end up with megaloblastic anemia. So till now we talked about three causes that alcohol makes. It can do very easily the sideroblastic anemia, but it can do also only macrocytic anemia because of the toxicity to the bone marrow, but also because it sort of supplements other energy intake, and that's why the alcoholics are not eating vegetables, etc., and not getting folates and B12. That's why they can also have megaloblastic anemia. And still, so it's pretty hard. If you're having megaloblastic anemia, it could be either from folate or from B12 deficiency. And now, how to tell the difference? And now we're getting to the beginning where I told you about the MMA, the methylmalonic acid. And remember, when you don't know if it's because the neurological signs, they don't have to be like obvious. Like B12 deficiency can be with or without neurological deficit. So the MMA will really help you in this case. So to tell apart B12 deficiency, adrenal, remember you will check for increased MMA in blood, and this will very likely support your diagnosis of B12 deficiency. And another very important comment is replenishment. So in case you will find someone has megaloblastic anemia and you want to help them and you want to give them B12 or folate or both, then you have to be aware of one thing. If you give B12 intracutaneously or folate or GAT, watch out. There can be one serious thing happening, and that is hypokalemia in both cases. And very dangerous one, because as these vitamins are deficient, the production of erythrocytes is decreased. If you replenish them, then bone marrow starts to work like hell and will build so many cells that actually this will decrease potassium levels in the blood, and this can really cause severe hypokalemia and kill the patient. So every time you're using B12 or folates for treatment, never forget to check the potassium levels, because this is such a big boost of erythrocyte production that can really decrease the level. So this is a very serious thing, and don't forget this. And still about B12 deficiency, remember also metformin, for example, metformin can block or interferes with the B12 absorption. So watch out on patients with metformin if they are megaloblastic. And again, I'm stressing out, especially if the pancreas fails in its exocrine function, again because of the inability to disbound the R protein and B12 bondage, the patients can get also deficient. So don't forget about pancreas. That problems with pancreas can also cause B12 deficiency. And as I mentioned in the first videos, in the folate and B12 metabolism video, of course, the other big group of causes of the megaloblastic anemias could be anti-cancer treatment. So don't forget the methotrexate that could cause megaloblastic anemia as a chemotherapeutic treatment. This is used for cancer, but also for example, rheumatoid arthritis, and trimethoprim, which is a antibiotic. So don't forget also anyone on anti-cancer drug can have megaloblastic. The different also 5-fluorouracil could cause megaloblastic anemia. So don't forget about these. Also, one more interesting thing about B12 before we get deeper in B12. So B12 in general, don't forget 1/3 of patients that have megaloblastic anemia due to B12 deficiency can have normal levels of B12 in the blood, because normally you measure the levels of B12, and 2/3 they will have a decrease, so it sort of confirms the diagnosis or really helps in that, but 1/3 will not. And this is because transcobalamin is also a acute phase reactant, and this could mask the B12 levels. So that's why you again will perform and check for MMA, and if it is increased, MMA can be increased, although the levels of B12 can be normal. In this case, again, it supports the diagnosis of B12 deficiency. And to go even deeper in the causes of B12 deficiency, we're going to go to another page, and over here there are two major groups of the cause, and the most important one and the most common cause of B12 deficiency is pernicious anemia. And the other causes could be, as I said, the exocrine pancreatic insufficiency, or pancreas, or it could be a intestinal resection or some kind of malabsorption, or it could be infection sometimes like treponema. Okay, but anyways, the most common cause is pernicious anemia. And to test if it's pernicious anemia or not, it's very simple. You just check for antibodies, and if the patient will have anti-intrinsic factor antibodies and anti-parietal cells antibodies, this confirms the cause that it's pernicious anemia. If it's going to be positive for these, if it's negative, you will have to look for other causes. So to summarize it once again, remember that if it's only macrocytic anemia without any polysegmented neutrophils, so it's not megaloblastic, very commonly it's alcohol cause of its toxic activity. If it's megaloblastic anemia, it could be B12 deficiency or folate deficiency. Common thing with alcohol and B12 deficiency is the peripheral neuropathy, which is the most common. In case of megaloblastic anemias, the MMA increased will really help you if you're thinking of B12 deficiency, in contrast to folate deficiency, where MMA should be normal. Also, don't forget, if you're treating with B12 or folate, always check the potassium, because it could get really low. And also, don't forget, if there is a B12 deficiency, you should rule out pernicious anemia. So you're going to check for intrinsic factor antibodies and also anti-parietal cells antibodies. Well, and that's all for the macrocytic anemias. So, thanks for watching. And don't forget to subscribe and ring that bell. And as always, check the description below for supplementary questions and other materials.